Hopefully everyone's got their second cup of coffee, caffeinated and black. We're going to get started with session number 2. It's a real pleasure to introduce our next speaker, Marion Peters from UC San Francisco. Marion is, just an incredible clinician, and she's going to talk to us on the practical approaches to alleviating your PSC symptoms. And I have to say, it was over, I think, 10 years ago I asked Marion for her little handout on your itch protocol, and I still use that same protocol today. It's been very helpful. Marion has a wealth of knowledge, and she's got the Aussie attitude to kind of just cut through all the stuff. Yeah. So I think it'll be a wonderful talk. And so Marion Peters, Chief of Hepatology Research and Professor of Medicine from UC San Francisco.
Thanks, Chris. It's a pleasure to be here. And I'm going to sort of go over the symptoms of PBC and what can you do. First of all, we know PSC, correction. PSC can be a silent disease. You may have no symptoms. And up to 40% of patients are asymptomatic at presentation, even if they have increased liver enzymes. So these are the symptoms we see. Very commonly, none. Fatigue is very prominent in patients, often leading some naughty people to say you're depressed when you really have liver disease. Oops. Pruritus or itching is common. Jaundice, abdominal pain, weight loss, fever, chills, hyperpigmentation. So let's talk about fatigue. It's important to exclude other conditions. People with autoimmune disease commonly have other autoimmune diseases, so hypothyroidism or thyroid disease is quite common, and patients should be checked for that. Also anemia, if you have concomitant inflammatory bowel disease, you may be anemic. Don't take fatigue as, make sure you don't have a medical condition underlying it apart from your PSC. Urso doesn't seem to help with fatigue, may help mentally, but doesn't help, I don't think, very frequently. And fatigue usually cannot be explained by depressive symptoms. It may be centrally mediated with hormones that are released, and sometimes if the serotoninergic neurotransmitters are involved, then an SSRI antidepressant may help. So if your physician suggests trying it, it's worth a try. It doesn't mean you're depressed, it might be the central mediation of fatigue. What about itching? Itching is common. We have to make sure in PSC it's not due to obstruction of one or some of the bile ducts within the liver causing pain, infection. That's a critical issue to resolve. And many studies have suggested bile acids as the cause, endogenous opioids, histamine, or even autotaxin. I'll talk a little bit about that. It's important to rule out obstruction of the bile ducts if a patient suddenly develops itching, that it's often associated with a change in the liver enzymes, an increase in bilirubin, and with evidence on imaging studies of a dilated duct behind the obstruction. So we'd start off with an ultrasound and repeat your liver tests. If there is evidence of obstruction, we may need ERCP or MRCP if there are new changes. Oh dear, this sort of got weird. What are the symptoms of cholangitis or infection, obstruction? So when you get an obstruction in the bile duct, behind it you get stasis or slowing of the bile flow, and that leads to infection, and if you don't do anything about it, eventually to stone. Can be nausea or vomiting, fever, chills, pain in the right upper quadrant, may also be in the chest or the upper back or the right shoulder, jaundice or yellowing of the eyes or skin. Severe symptoms when you get bacteria in your blood, you have a low blood pressure, fatigue, serious lethargy, confusion, pale stools, dark urine. That's something to immediately call your doctor to rule out. If you have narrow or blocked bile ducts, that can cause bacterial infection, and many patients with PSC need to take repeated courses of antibiotics or even rotating antibiotics later in the course of disease. When you have a procedure, you'll need antibiotics, whether that be endoscopic procedure or abdominal surgery, to treat the possible infections. But what if you don't have that? You just have itching. It's a common symptom in all forms of cholestatic liver disease, and it's not correlated with the level of bile acids, of endogenous opioids, of histamine, of tryptamine, or substance P. We, as your doctors, will say, well, we treat things to decrease the bile acids, and that improves the itching. It's because we don't actually know what it is, so we say that, and it makes us feel better, but it's not actually true. But there's something in the bile acids that we treat that improves. And one of the suggestions is autotaxin, which is a protein in the blood. It's an enzyme that produces LPA, lysophosphatidic acid. And if you inject LPA into the skin of mice, the mice scratch. And patients with itching and cholestasis have higher LPA levels. So here's the data. Ooh, no, here it is. So here are healthy controls, first left. Here are patients with cholestatic liver disease who aren't itching. Here are Hep C patients who don't usually itch. And here are the cholestatic patients who itch, much, much higher. So I was incredibly excited when I saw this data 8 years ago and thought, next step is an antibody to treat it or a drug to interfere with it, and it's going to go on my itching protocol on page 2, which is the hard one. If page 1 doesn't work, page 2 is the hard things. Nothing's happened. So we've identified something that you put it, I know we're not big mice, but you put it in mice and they itch. We've shown that in patients they have more of this when they're itching. You'd think that there's a drug company out there that are going to work out how to inhibit it. Hasn't happened yet. And if anyone else knows, they can tell us in the Q&A. So how do we treat itching now? There's symptomatic treatment, there's dermatologic treatment in the skin, there's treatment in the gut, and there's treatment in the liver. So we start with the skin. We know that if you're cooler, you have less itching. So if you live in Sacramento, you've got to stay cool. You can't go out today and just hang in the sun. It's going to be 104, I checked this morning. You decrease the shower temperature. You don't have a cold shower, just decrease it a little bit. Have fewer, lighter clothing, air conditioning, and you minimize dry skin. Dry skin itself causes itching. It doesn't mean you have liver disease. So what I tell my patients, you get out of the shower, don't rub yourself dry, pat off, and then use moisturizing soaps. Don't use Ivory, use Dove. I don't have any shares in it. It's cheap, it's frequently on sale. And then after you dry off, use Eucerin cream, not the lotion. The cream is thick like goop. Take a glob and put it all over the itchy parts. You can put it on as frequently as you like. Your loved one can put it on your back. You can put it on your face. It's safe. It doesn't smell. It doesn't have any side effects. You can use it for children. And there are very expensive alternatives if you want to know them. Also, at the NIH about 25 years ago now, the immunologists showed that doxepin actually stabilizes the mast cells in the skin. Doxepin is an antidepressant, usually used at 100 milligrams or more, but using tiny doses, 12.5, 25, or 50, taken at night, it can decrease the itching. Most people have more itching at night, because at night you don't have anything to do except think about your symptoms, whereas during the day you've got life to do. So I think that's the reason people have it, but at night, glob on the Eucerin, take a doxepin. Patients with liver disease, just a little bit goes a long way and may make you very sleepy, especially smaller patients. So start off with 25, you may need less, you may need more. What about the gut? There are anion exchange resins that bind bile salts in the gut, so you poop it out, decreases the itching. Cholestyramine or cholesterol are the two. You start off with 1 packet twice a day, 3 times a day. You can increase or decrease. If 2 packets 3 times a day doesn't work, more is not better. It's sort of grainy, sandy. My patients say, whatever food you take it with ruins your taste for that food. So they sort of rotate, or some really tough people just take it with water. I could only get it down with sweet raspberry soda. It's pretty disgusting. Anyway, you separate it from other medications by about 2 hours. If you take urso and cholestyramine together, you poop them both out. Not a good idea. What about in the liver? To decrease the bile salts and whatever it is in the bile salts that's increasing the itching, improving bile flow, we use urso. Not as part of the debate you just heard, but to treat the itching. We use usually 13 milligrams per kilogram per day at night. Why do we do it at night? Well, that's the way we did the studies for PBC, and we use bear bile, and bears hibernate for 6 months, so they're asleep and good things are happening, so that's why we do it, but we actually have no data. You can also use rifampin, which induces the enzymes in the liver to help bile flow, as Dr. Bolus told you. I don't usually use that first line, that's my second page. Opioid receptor antagonists to centrally decrease the effect of itching, second page. You often need to be in hospital to get the IV opioids, but there are oral opioids you can get if the IV opioids work. How do we monitor patients with PSC? So it's really important, as Dr. Medici told you, that you need to evaluate your vitamins, your nutrients, that patients yearly have to have assessment of vitamin D and vitamin A. If your vitamin D is low, you need, I think I might have to slide on this. No, I don't. In a minute. Calcium, we check 24. If you're taking oral calcium and you're taking a lot of it, I check how much you're peeing, because there's nothing worse than having a kidney stone. My patients say it's the worst thing ever, and they yell at me if I increase their calcium and you got one. Get a bone density, and I'll talk about that. Get vitamin A. If you have osteoporosis, we need to check the calcium, the 25-hydroxy vitamin D. Sometimes hormone replacement therapy is not contraindicated in patients, and it is helpful, but in some patients you have to talk to your doctor about whether you can take it. The risk-benefit, which as far as I can tell changes every 4 years. Some patients who don't respond need calcitonin or bisphosphonates. And water-soluble vitamin A, because if you have cholestasis, you're not going to absorb the normal vitamin A. So initially, screening for metabolic bone disease is with a bone density, a DEXA. If it's normal, we repeat it usually in 3 years. If it's abnormal, then we go into evaluating vitamin D and checking calcium and starting treatment. Osteopenia is a T-score between 1 and 2.5 standard deviations, and osteoporosis lower than 2.5. And the risk of osteoporosis is low in PSC, about 4 to 10%. How do we treat it? Some patients with vitamin D deficiency have bone pain. The vast majority of patients with vitamin D deficiency have 0 symptoms. If you live in the Bay Area, lots of patients have vitamin D deficiency. We don't get sun if you live in San Francisco. If you live in Sacramento, that is not a problem. But all my patients with liver disease, I treat 25 hydroxyvitamin D. What you take in through the sun is vitamin D. It goes to the liver where it's turned into 25 hydroxy. Then it goes to the kidney where it's turned into 125 hydroxy. Then 125 is what puts calcium in the bones. So if you have a bad kidney or a bad liver or a very shady environment, they're the different reasons for vitamin D deficiency. If you have a normal vitamin D, I recommend patients take 1 to 1.5 grams of calcium with vitamin D a day. If vitamin D is low, we start off giving D2 as 50,000 units, so a huge whack once a week for 8 weeks. I always order it on Sunday. And then after that, 2,000 a day for 2 months. Then we check. If your vitamin D is normal, that means your liver is making the 25 and your kidney is making the 125. Then we just monitor your vitamin D every year. If the vitamin D doesn't increase with that oral medication, then you need a prescription vitamin D that bypasses all those enzymes and is 125 vitamin D calcitriol. If you're on calcitriol, measuring vitamin D doesn't work because calcitriol is 125 and what we measure is 25 because the 125 assay is pretty bad. Why do we use 125 and not 25? Because the insurance companies, it's cheaper to give a patient 125 than 25, not because it's better. And if patients have proven osteoporosis, we put them on calcium, we've checked their vitamin D, we've given them supplements, then they may need calcitonin or bisphosphonates. And often we ask the patient to go to the endocrine group for proper evaluation of that. What about self-care? What can you do to improve your quality of life with PSC? Fatigue is common, and some treatments may decrease fatigue, but your signs and symptoms may persist. You may find relief with complementary and alternative medicine, as you heard from Dr. Cohen yesterday, such as walking, exercise. It helps your metabolism, it helps your muscle strength, it helps your overall body health. Spending time with friends and family usually improves your mood. Depends on your friends and family. Stress management techniques such as meditation and relaxation is often very, very helpful, and yoga for some people who like being upside down. Nutritional support is critical, and you heard a lovely talk from Dr. Medici before the break, because people with PSC and who are jaundice or yellow may have trouble absorbing vitamins A, D, E, and K. Vitamin A is what causes night blindness, so we always check it. If you need supplementation, give the A-Dex she recommended. Sometimes it doesn't work. You used to be able to buy Aquasol at the health food store, but not anymore. But they do have some water-soluble vitamin A. We do not have it in our pharmacies. Vitamin D, I've talked about. We need to measure your vitamin D every year and supplement as necessary. Vitamin E is a major problem in children, especially in growing children, that needs to be checked. It can cause a peripheral neuropathy also in adults, but that's pretty rare. And vitamin K is your prothrombin time, or INR, your clotting, and that gets checked every year anyway. Remember what you heard before, that even with a healthy diet, patients may not get all the nutrients they need. And we really push nighttime snacks in patients with cirrhosis, especially if they have decompensation with ascites or confusion, swollen belly, etc. And the nighttime snack we prefer is protein, But I have to say, if you don't like protein, I let them take what they like. I have one patient who takes ice cream, but you know, get the calories in if you can. Your doctor may recommend vitamin supplements, and you may need to take calcium and vitamin D, and most patients should be on it. So finally, health maintenance. Don't drink alcohol, because you've already got one problem, don't add another one. Remember, you must be vaccinated against hepatitis A and B and checked. Use care with chemicals at home and at work. Maintain a healthy weight and a healthy diet, which is sort of un-American, but do it anyway. Follow directions on all medications, both prescription and over-the-counter, and make sure your pharmacist and any doctor you see for other issues know that you have liver disease. All the drugs, no, that's not true. 99% of the drugs given are metabolized by the liver. So your patients with PSC are no more likely to get drug toxicity than I am. But you already have one problem, you don't want to add to it, so you want to make sure doctors know you have liver disease. It might change the drug they choose. And talk to your doctor about herbs and spices, because some of them can be harmful for your liver. Make sure if you're taking herbal medicines, you go to someone who really knows what they're talking about and have used these drugs in patients with liver disease. Thank you very much.